So hello, good evening everyone, and welcome back to the DBA platform where we are taking live masterclasses. And as you all have been attending my classes, the last class was about respiratory failure, and we were talking about respiratory failure, and we had taken part 1 of the respiratory failure. So I'll quickly go through the part till where we had completed, just maybe a quick revision. So when we talk of respiratory failure, we will be covering the entire concept of respiratory failure here. So we began with the basic concepts. We went through the respiratory tract, the conducting zone, and the respiratory zone. We had gone through the histological part of the epithelium, the type of cells that line the alveoli, that type of cells that line the trachea and the respiratory bronchioles. We discussed the alveolar sac. We discussed the ventilation, that is the air coming in the alveoli. Then we discussed the capillaries around the alveoli, that is the perfusion part. We discussed the ratio of ventilation perfusion ratio, that is VQ ratio. The ideal ventilation perfusion ratio should be VQ is equal to 1. And this is the ideal ratio that we all want, but that does not exist. The VQ ratio at the apex of the lung is 3, that is there is wasted ventilation. Ventilation is more and perfusion is less. At the base of the lungs, the VQ ratio is 0.6, that is wasted perfusion, where the perfusion is more and ventilation is less. So if you look at the diagram here, diagram wise, if you look at this, the apex of the lung where the ventilation is less, perfusion is less, but perfusion is much lesser than the ventilation. So the ventilation is still more and it is 3 times that of perfusion. So VQ ratio is 3 at the apex. Ventilation is equal to perfusion and in the middle zone, that is zone 2. And both ventilation and perfusion is high in the base of the lungs, but the perfusion is much more than the ventilation. So the VQ ratio is 0.6. Now we also studied about the hemoglobin part, that is the hemoglobin has 4 polypeptides, that is the adult HbA. We are talking of the HbA2 format, that is alpha 2 beta 2. And we studied that it carries some 4 molecules of oxygen. One hemoglobin is bound to 4 molecules of oxygen. So it exists in 2 allosteric forms, 2 forms, isoforms, that is the taut, which we know is the taut or deoxygenated, or the tissue form, or what we learned just to remember the mnemonic was taut tissue in tatters, that is poor. It is poor in oxygen. Then we also learned the relaxed form, R for rich, the R rich form of hemoglobin, that is rich in oxygen, the respiratory area. So rich, relaxed R. So why is it so? Because it has no negative allosteric. It exhibits positive cooperativity. And this positive cooperativity makes it relaxed in the isometric structure. It becomes relaxed. So it can bind more oxygen. So what are the factors that favor taut over relaxed? We want the taut form because this is the form that will release oxygen to the tissues. So anything we learned in our last classes that the oxygen dissociation curve, it is a sigmoid shaped curves. So in tissues, this curve is shifted to the right, that is oxygen is deloaded. So anything that increases chloride, increases H ions, that is acidosis, increases CO2, that is hypercapnia, increases 2,3-BPG or increases temperature, all these will cause a right shift of the oxygen dissociation curve. So the mnemonic we learned was ace bats right-handed. So this is what the mnemonic we learned, ace bats right-handed. So acidosis, rise in CO2 and your exercise, BPG, 2,3-BPG, high altitude and the temperature rise, all these factors will cause a rightward shift. So this is your oxygen dissociation curve and you will find that every time all these factors rise, this oxygen dissociation curve is shifted to the right. Now, when is this curve shifted to the left? That is the decrease in dissociation or the oxygen is not deloaded from hemoglobin. That happens in renal hypoxia. because there is increased erythropoietin causing increased erythrocytosis. And because of this, there is increased binding of oxygen to the hemoglobin. So there is a leftward shift. So till here, we had learned in our last class or the last session of respiratory failure. So picking from here, we have another component that is myoglobin. So whenever you will find that there is a muscle injury or a muscle crush injury, this myoglobin level rises in the system. And this myoglobin is a monomer. It is a monomeric form of globin. It's a globin protein. This does not show positive cooperativity. And as a result, the myoglobin oxygen dissociation curve is not sigmoidal. It is a parabolic curve. It will rise and flow in the parabolic pattern. Now coming to the another component of the gas, one of the other important gaseous system, that is the gas in the blood, that is CO2. So we inhale oxygen and we exhale CO2. So another important gas to discuss is the carbon dioxide. So now this CO2 is transported in three forms. 90% it is transported as bicarbonate, that is HCO3, bicarb. And remaining 5% is bound to the hemoglobin, but it is not bound to the heme component like oxygen. It is bound to the globin component. It is bound to the globin component, and that is known as carb-amino-hemoglobin. So carb-amino-hemoglobin is existing in 5% format. Remaining 5% of the CO2 is dissolved. So what are the three forms of CO2 traveling or transportation in our blood? 90% as bicarb, 5% as carb-amino-hemoglobin, and 5% is dissolved. Now what happens? In the lungs, the oxygenation of hemoglobin will promote dissociation of H from the hemoglobin. So this shifts the equilibrium towards CO2 formation. Therefore, CO2 is released from the RBCs. So what happens in the lungs? In the lungs, there is high level of oxygen is existing. So this high level of oxygen gets bound to the hemoglobin. The hemoglobin in the blood, in the lungs, is coming as reduced form from the tissues, that is HHB form it is coming. In the HHB form, when it reaches the lungs and it meets high oxygen, this H ion is released, and this oxygen is bound and it becomes your HbO2. And this H ion which is released, this combines with the HCO3 and which releases CO2 in the presence of carbonic anhydrase, and the CO2 is then exhaled out, and the remaining H2O gets back, the water that gets back into the blood. So this release of CO2 from the RBCs, that is from the HHB format, when H is released and this H ion binds with the bicarb to form H2O and CO2, this is known as the Haldane effect. So under the Haldane effect, CO2 is released from the RBCs and we expire out the CO2. Now this HbO2, when it moves back to the tissue, so in peripheral tissues, there is high H ions from the tissue metabolism, and that shifts the curves to the right. Here, the oxygen is deloaded from the HbO2 format, and this unloading of oxygen in the tissues is known as the Bohr effect. So you will get very important questions here. What is Haldane effect and what is Bohr effect? So Haldane effect is the release of CO2 from the RBCs in the lungs. This happens in the lungs. Whereas unloading of oxygen from the hemoglobin, from the HbO2 format in the tissues, in the presence of H ions, is the Bohr effect. So majority of the blood CO2 is carried at 90%, we just learned, is carried as bicarb in the plasma. So this goes back in the dissolved form to the lungs, where again under the Haldane effect it is converted into CO2 and the CO2 is expired. We exhale. Just look at this diagram and you will understand better. So at the peripheral tissue level, what is happening? This is the CO2 which is dissolved here. 5% is dissolved in the plasma. This CO2 binds with the water here and forms, in the presence of carbonic anhydrase, it forms bicarbonate, that is H2CO3. And this H2CO3 then releases the H ions and the bicarb. This bicarb is the 90% format of the CO2 which is transported in the blood. Now here, this H ion binds with the hemoglobin, which is the deloaded or the deoxygenated hemoglobin, and it forms the HHB. This HHB goes back to the lungs. And at the lungs, what happens? In the lungs, this H ion is released and it binds to another molecule of oxygen and forms HbO2 and comes back to the tissues. Now, some part of carbon dioxide is also dissolved, that is 5% is dissolved in the plasma, and 5% is bound to the hemoglobin, but to the globin component. Remember here, not the heme component. So it is bound to the globin component. So 5% is bound to the globin component, 5% is dissolved, and 90% travels as HCO3. And this deloading here, which is happening, this is known as the Bohr effect. And in the lungs, when the release of CO2 will happen, that will be the Haldane effect. Now, what is the partial pressure of oxygen? Partial pressure of oxygen, this is the amount of oxygen that is dissolved in the blood. Now, that we already learned in our first part that 2% of the oxygen is the dissolved oxygen, and this forms the partial pressure, that is PaO2, the arterial partial pressure of the arterial oxygen. So that is PaO2. This is formed by the dissolved oxygen, and that is existing only 2%. It primarily will measure the effectiveness of the lungs in pulling oxygen into the bloodstream from the atmosphere. So normal PaO2 is 75 to 104. Practically, it remains somewhere around 95 to 104. So normal pressure at arterial level is 95 to 100. Now remember this, alveoli will have a 100% PaO2. That is, the entire oxygen there is in the dissolved form, and the partial pressure of oxygen in the alveoli is 100%. And we denote the partial pressure of oxygen in alveoli by a capital A. Please remember that when we denote partial pressure of oxygen as P with a capital A, we are talking of alveolar partial pressure. Whereas when we are denoting it with a small a, we are talking of partial pressure of oxygen in the arterial blood. So the gradient of alveolar to arterial is around 5%. And this 5 kilopascal, this 5 millimeters of mercury pressure difference is responsible for the shifting of oxygen from alveoli to the arteries. We know everything in the world moves across or along the gradient from high pressure to low pressure, from a height to the lower side. So along the gradient, the oxygen also moves. So from the 100% partial pressure of oxygen in the alveoli, the oxygen moves to the lower partial pressure of the arterial blood, that is around 95 to 104 millimeters of mercury. So that is alveolar arteriolar oxygen gradient. If this partial pressure of oxygen in the arterial blood drops below 60, we label it as hypoxemia. Again, another very important term. What is hypoxemia? Hypoxemia is decreased partial pressure of oxygen in the arterial blood below 60 millimeters of mercury. Now you have to understand what is hypoxemia and what is hypoxia. Though we very often use the two terms as interchangeably, but they are not the same always. So though we are using it interchangeably, but they are not always same. That you have to understand. This I have already talked. What is alveolar oxygen and what is arterial gradient? That is PaO2, the capital A, and PaO2, that is with a small a, that is arterial, and this is alveolar. This gradient is the difference in the partial pressure of oxygen between the alveolar PaO2 and the arterial PaO2. Now for calculation purposes, this again I explained, the alveolar pressure is always 100 millimeters of mercury, whereas arterial oxygen pressure is around 95 millimeters of mercury. So So the A is to A gradient is somewhere around 5 millimeters of mercury. And this gradient plays the vital role in the transmission or transfusion of oxygen from the alveoli to the blood capillaries. That is, the ventilation is perfect, perfusion is perfect, but ventilation, perfusion, the diffusion of gases will only happen when this gradient exists. So now this calculation of this gradient is useful in differentiating the causes of hypoxemia. Suppose the arterial pressure is less than 60, that is hypoxemia. So what are the various causes? It can happen due to ARDS, that is, alveoli is normal, having 100%, 100 millimeters mercury oxygen. The arteries are also normal with having oxygen gradient of say 95 millimeters of mercury. But still, because of ARDS and lot of interstitial deposition of proteins, the plasma proteins in the ARDS, this diffusion of gases does not happen. And that is why there is increased alveolar arterial gradient, and that causes hypoxemia, because eventually this oxygen will keep on getting utilized by the tissues and the arterial oxygen gradient will keep on dropping. Now, this mismatch between ventilation and perfusion in the lungs because of this ARDS, hypoxemia can also happen due to extrapulmonary causes, like there is paralysis of the diaphragm. So because of the diaphragmatic paralysis, this is very interesting. There will be no diffusion happening because the muscles are not able to breathe. But in that case, the gradient does not increase. The gradient does not increase because the alveolar oxygen and the arterial oxygen levels, they remain the same. There is drop in the arterial oxygen gradient as well as the alveolar oxygen gradient because the alveoli are not ventilating. So the alveolar oxygen levels also decrease just as the arterial oxygen level decreases. Now, what is a medically significant gradient? When we talk of medically significant gradient, we were just talking so far about examples. But if you talk of medically significant gradient, the alveolar arteriolar gradient only becomes significant if it is more than 30 millimeters of mercury. Now, how does it happen? This gradient increases with age also. Normally, how do you calculate? The formula is the gradient is calculated by age upon 4 plus 4. So, for a gentleman of say around 80 years, this gradient will become 24. So, still it is not very, very significant. This will only become significant when, because of some reasons, the gentleman is not able to breathe. That is because of the flail chest, because of the diaphragm paralysis, or because of the diffusion defects, you will find that this gradient becomes more than 30. It is only then it will become significant. Otherwise, age-related changes will be there and they will not be considered significant because they are still considered normal if they are less than 30. So now coming back to our definition, hypoxemia, it is low arterial pressure of oxygen below 60 millimeters of mercury. This is a state of oxygen deficiency in the arterial blood. Just remember, we are still talking of low oxygen pressure in the arterial blood, and that is hypoxemia. It can have many causes. It can have causes beginning right from the lungs level, that is the lungs are not properly ventilated because of whatever reasons, or it can be because of the diffusion defects, or it can be because of the gaseous diffusion defects. So hypoxemia can have many causes. Now this hypoxemia, if it is translated into tissue oxygen deficit, please try to remember what I'm talking. If this hypoxemia, that is low oxygen pressure in the arterial blood, fails to transfer sufficient oxygen to the tissue level, then it is termed as hypoxia. So hypoxia is oxygen deficiency at the tissue level. So it often causes hypoxia if the blood is not supplying enough oxygen to the tissues. Though most often hypoxemia is the most common cause of hypoxia, but not always. Hypoxemia may cause hypoxia, or sometimes hypoxia may exist without hypoxemia. So hypoxemia is low partial pressure of oxygen in the blood. Now hypoxemia with increased gradient. That means the arteriolar oxygen level is low, but alveolar oxygen level is still high. That can happen with ventilation defects. For example, alveoli are perfused, but there is impaired oxygen delivery to the alveoli. The alveoli itself, they do not have oxygen enough. Like there is alveolar collapse. There is airway collapse in atelectasis. For example, respiratory distress syndrome, we just read because of the deposition of the proteins here. Or there are perfusion defects when alveoli are ventilated, but there is no blood supply. The perfusion defects, as happens in pulmonary embolism. So these are all causes of increased gradient. One is because of the decreased blood supply, one is because of the decreased ventilation. Then there are diffusion defects. That is, oxygen cannot diffuse through it. For example, a case of interstitial fibrosis. If there is lung damage themselves, so oxygen cannot diffuse through the alveolar capillary interface. Or there is pulmonary edema. Again, a cause where there is interstitial fluid. So there is a lot of fluid between the alveolar wall and the arteriolar wall. Then there are right to left cardiac shunts. For example, TOF, in tetralogy of Fallot, there is overriding of the aorta. So because of this overriding of the aorta, there is blood shunting from the right side directly into the arterial blood. So there is right to left cardiac shunt that is seen in TOF. All these cause high alveolar arteriolar gradient hypoxemia. Now what happens if there is hypoxemia but the alveolar arteriolar gradient remains normal? That can only happen when the alveolar oxygen is also low. And when can that happen? When the person is not breathing. So there is no respiration or decreased respiration, like depression of the respiratory center in the medulla. If the respiratory center in the medulla itself is defective, the person is not breathing enough. So alveolar oxygen levels are also low. For example, if there is any sedative overdose like barbiturate overdosing, or if there is a brain injury. Similarly, if there is upper airway obstruction, for example, if there is a epiglottitis because of H influenza, there is severe epiglottitis and there is no breathing. Breathing itself is defective. There is croup because of para-influenza virus. Here there is mucosal edema causing narrowing of the trachea. There is a trachea, the tracheal lumen itself is narrowed down because of the tracheal edema. Then what happens in chest bellows? That is muscle paralysis of the respiratory system. So the respiratory, either the intercostal muscles themselves are paralyzed or the diaphragm is paralyzed. So that causes chest bellows, for example, diaphragm paralysis or amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis with degeneration of the anterior horn cells. Now, once again, hypoxemia, I'm repeating it, PaO2 less than 60. Now, what about the partial pressure of carbon dioxide? Now, partial pressure of carbon dioxide, unlike to oxygen partial pressure, is entirely dependent upon the ventilatory functions. Why? Because tissue metabolism is anyways all the time going on. So the CO2 production is always ongoing. So what can change is our ventilatory capacity to exhale out. So partial pressure of CO2 will always depend upon the ventilatory efficiency. Normal PaCO2 is 40 to 45. So at the arterial level, it is 40. At the venous level, it is 45. So PaCO2 is directly related to alveolar ventilation. If you hyperventilate, that is you breathe out more CO2, the partial pressure of CO2 will drop. If you hypoventilate, because of again the depression of the brain center, the respiratory center, or because of muscle paralysis, or because of the over sedation, there will be rise of partial pressure of CO2, that is the partial pressure of carbon dioxide will rise. That is, it will be more than 45 millimeters of mercury. So what will be the sign or symptoms of hypoxemia? If there is hypoxemia, you will be dyspneic because the oxygen supply to the tissues is insufficient and you will feel oxygen hunger. You will have a craving for oxygen. That is, you will start hyperventilating, and that is, you will get dyspneic. Then you will be agitated, you will be confused, and there can also happen central cyanosis. We just read central cyanosis in our last class, that we have, because of hypoxemia, you can have central cyanosis. Now, if this hypoxemia is long standing, if it is short standing and for shorter duration, and you get more oxygen, that you are supplied with 100% oxygen, you can overcome your signs and symptoms. But if this hypoxemia is long standing, body tries to compensate. And how does body compensate? By increasing the number of RBCs. Because if the total number of RBCs rise, the total hemoglobin will rise and the total oxygen content will rise. So what will happen? There will be polycythemia. But because of polycythemia and because of long-standing hypoxemia, there will also be pulmonary hypertension. So pulmonary arterial hypertension, because pulmonary artery will be overloaded with work. So there will be pulmonary hypertension. And because of the reverse failure, or what we call the congestive failure or back failure, there will be right ventricular failure, that is known as cor pulmonale. So there will be right ventricular failure or the cor pulmonale. What will be the signs and symptoms of hypercapnia? If you are having a high level of partial pressure of CO2, that is PCO2 is raised, you will have headache, there will be vasodilatation, tachycardia, bounding pulse, tremors, flap, papilloedema, drowsiness, and coma. So these are the signs and symptoms of hypercapnia. Now, once again, just revising the difference of hypoxemia and hypoxia. They are interchangeably used, but they are not synonymous. Hypoxemia is low partial pressure of oxygen in the blood. So arterial oxygen pressure is low, whereas hypoxia is a condition of tissue deficit of oxygen. So tissue oxygen deficit we cannot measure directly. So what do we measure? The metabolic product of tissues. So if there is rise in the lactate level, if there is rise in serum lactate levels, we think we are dealing with tissue hypoxia. So hypoxia and hypoxemia, they may or may not occur together. Usually they occur together. Usually hypoxemia is the most common cause of hypoxia, but they may still not occur together. As we just talked, there can be conditions when there is tissue hypoxia. For example, there is tissue necrosis. So what will happen? There will be tissue hypoxia. There is muscle crush injury, or there is cyanosis. So there are reasons where the tissue is having deficit of oxygen, but the blood is having sufficient oxygen. So without hypoxemia, hypoxia can exist. Similarly, there is hypoxemia, that is low oxygen in the blood, but the body compensates by increasing the cardiac output, by increasing the blood supply. So tissue hypoxia may not happen immediately. So hypoxia may not present in patients with hypoxemia if the patient compensates by increasing the oxygen delivery, that is increasing cardiac output, or decreasing the oxygen consumption. This is also another method. You can decrease your requirement, and that is seen and that is utilized medically in cases of head injury, where we apply the therapy of hypothermia. So we create an artificial hypothermia, that is we decrease the body temperature so that the need of oxygen itself is reduced. And this is very common in head injuries, where the brain is given kept in very low temperature so that brain tissue can be survived in low oxygen supply. Conversely, patients can have hypoxia without hypoxemia, that is oxygen delivery to the tissues is impaired. If tissues are The oxygen delivery to the tissue is not impaired, but the oxygen tissues are unable to use the oxygen. So hypoxemia is but the most common cause of hypoxia so far. That is what we talk of. So depending upon this, there has been a classification of what are the types of hypoxia. So there can be hypoxic hypoxia, that is generalized hypoxia. This refers to hypoxia from inadequate saturation of blood oxygen, that is hypoxemic hypoxia is referred to as hypoxic hypoxia. For example, there is no oxygen in the system, in the environment itself. Like you go to high altitudes, you're going to Alps, you're going to high mountains. So oxygen in the atmosphere itself is low. There is decreased atmospheric oxygen pressure, decreased oxygen supply. So such conditions will cause hypoxemia and hypoxia. Then there is decreased lung ventilation. There is again hypoxemic hypoxia, or there is respiratory diseases when the lungs are not able to breathe in. So with this type of hypoxia, if you give high oxygen pressure, the partial pressure of oxygen in the arterial blood is low, and that is causing hypoxemia, and this hypoxemia is causing hypoxia. This is known as hypoxic hypoxia. Now, some of the causes of hypoxic hypoxia we just talked, that is high altitude. Or another important thing is use of nitrous oxide. Now, nitrous oxide is actually a laughing gas. So if you use this recreational gas, if you use it very often for the recreational purposes of laughing a lot, the oxygen binding is decreased, the oxygen availability is decreased, but the carbon dioxide level, because we are breathing, we will have high levels of carbon dioxide. The tissue metabolism is going on. So the oxygen level is low. So there is hypoxemia with high carbon dioxide. So that is with hypercapnia. We will come to that also. Now, in case of sleep apnea or obstructive sleep apnea, during sleep, you will find that the patient sometimes is not breathing because of obesity, because of the huge fat mass in the neck area, and because of there is a very, what do you call, a thick tongue. The tongue falls back and closes or covers the epiglottis. So because of this thick tongue, there is falling of the tongue back, because that can also happen in myxedema. There can be a thick tongue which falls back during sleep, or for some other reasons, the patient is not able to breathe during sleep and there is sudden apneas, and that causes hypoxemia. Then certain diseases which cause inadequate ventilation, like the bronchial asthma. There is respiratory arrest, or in conditions like COPD, again there is hypoxemia because there is lung defect and the lungs patient is not able to breathe. Then comes what is anemic hypoxia. Now, we just read what is hypoxic hypoxia, that is there is ventilation defect. Now, if there is hemoglobin low, that is low hemoglobin, where the oxygen carrying capacity is less, that is causing anemic hypoxia. So this refers to the capacity of the blood to carry oxygen is reduced. So that is anemic hypoxia. Therefore, inadequate level of oxygen are circulated around the body. Here, the lungs are perfect. There's no ventilation defect, but the oxygen carrying capacity of the blood is reduced, and that is known as anemic hypoxia. And this will cause tissue hypoxia. Like this happens in anemia when there is decreased amount of oxygenated hemoglobin, or it can happen in carbon monoxide poisoning. Now, hemoglobin has a very strong affinity for carbon monoxide. So if there is carbon monoxide available, hemoglobin will not bind oxygen, it will bind carbon monoxide. So that will lead to carbon monoxide poisoning, and that will cause anemic hypoxia. So just let us have a word about carboxyhemoglobin. Carboxyhemoglobin is a condition where carbon monoxide is bound to the heme component. So in place of oxygen, it is the hemoglobin is bound to carbon monoxide, which causes decreased oxygen binding capacity, that will cause left shift of the oxygen hemoglobin dissociation curve. Now, this is also very interesting. It causes decreased oxygen unloading in the tissues. So carbon monoxide binding itself is 200 times more as compared to the oxygen binding of the hemoglobin. Now, suppose this is a molecule of hemoglobin which is bound to 4 molecules of oxygen. This is a normal heme binding. Now here, in place of one oxygen, suppose this binds to carbon monoxide. So one molecule of one site which gets bound to carbon monoxide prevents the deloading of the other 3 oxygen molecules also. And that is why there is a left shift of the oxygen hemoglobin dissociation curve. This curve shifts to the left because this carbon monoxide does not allow the loss of other oxygen molecules also. If you give 100% oxygen under high pressure, that is hyperbaric oxygen, then in place of carbon monoxide, the hemoglobin will again bind to oxygen. Then comes what is histotoxic hypoxia. Histotoxic hypoxia is a condition where the oxygen level in the blood is normal. Oxygen delivered to the tissue is normal, but the tissue fails to utilize this. Why? Because the tissue is damaged. As the word goes, histo means tissue, toxic. The tissue itself is toxic. So there is cells cannot extract and absorb oxygen. It literally means that the tissues have been poisoned. Here, hypoxia is there is no problem here. You can have enough oxygen in the blood. The blood and the circulatory system all are good. But the problem is the tissue itself. And that happens, for example, in case of alcohol or drugs overdosing, or in case of cyanide poisoning. Now, this is a typical example why cyanide poisoning is fatal. Because even if you increase the supply of oxygen, increase the blood flow, you do whatever, but the tissue itself is damaged and unable to utilize the oxygen. Another example I gave you was the crush injury, where there is necrosis, myonecrosis. So this tissue itself is so damaged that it cannot use the oxygen. Then comes your cyanide. Just a word about cyanide poisoning. What happens is it disrupts your cytochrome oxidase. We know that cytochrome oxidase is the most common enzyme in most of the systems. This is an important enzyme in all cell respirations, and the tissue is now unable to use the oxygen because the cytochrome oxidase itself is damaged. Cyanide will lead to histotoxic hypoxia by poisoning the system that will utilize oxygen to create energy and prevent them from using the oxygen. Now, even if there is a lot of oxygen, the cells will experience hypoxia. Then comes what is circulatory hypoxia or a stagnant hypoxia. Circulatory hypoxia or ischemic hypoxia. Here, hypoxia, the lungs are fine, circulation is fine, tissue is also fine, but the blood is not flowing. There is stagnant, there is ischemia, there is blockage to the blood circulation. So the tissue is not receiving sufficient oxygen because the heart cannot pump the blood. The blood is not in a flow pattern. The heart is failing. So conditions like CHF, where the myocardium is not pumping out enough blood to the tissues. So the arteries carrying the blood, they get blocked. There is ischemia and the blood flow itself is not happening. So that is either a stagnant hypoxia or a circulatory hypoxia. Another condition which is an example of this stagnant hypoxia or a ischemic hypoxia is a sickle cell anemia. Now here there is a hemoglobinopathy. There is HbS variant. Now because of the sickle cell variant, there is stacking of the RBCs. There is Rayleigh formation, what we call is Rayleigh formation. And because of that, what happens? There is clotting of the blood capillaries and there is ischemia. And that causes ischemic necrosis of the tissues, which is very, very painful condition. And this is because of the sickle cell anemia. So there is hemoglobinopathy, which is causing Rayleigh formation and causing ischemic necrosis. Also, this hemoglobin itself is defective and it does not cause release of oxygen to the tissues. So it also produces anemic hypoxia as well as circulatory hypoxia. So now what we have few terms, how to they're very subtle terms, very, very minor differences, but you have to know them. Hypoxia is tissue hypoxia, when the tissue is deprived of oxygen. Ischemia is when the tissue is deprived of blood flow. impeded, either because the blood is not flowing, that is impeded blood flow, or if there is low oxygen in the blood, it is hypoxemia. Hypoxemia, that is decreased PaO2, or with dissolved oxygen also is decreased, with normal gradient, that is alveolar arterial gradient remains normal. That is happening at high altitude and because of hypoventilation. Why? Because the alveolar oxygen diffusion is normal, so the gradient is maintained, but the oxygen itself is low at high altitudes. So there is hypoxemia with a maintained gradient, that is high altitude or hypoventilation. But if there is hypoxemia with increased gradients, that means there is either a ventilation defect or a perfusion defect. So VQ mismatch is happening. Then there is diffusion limitations like fibrosis, or there is a right to left shunt. So again, just summarizing, ischemia means loss of blood flow. Hypoxemia means decreased arterial oxygen. Hypoxemia means decreased tissue oxygen delivery. So what is partial pressure of oxygen? It includes your oxygen dissolved in blood, and that is around 95 to 104. What is saturation of oxygen? That is hemoglobin oxygenation. That is the amount of hemoglobin existing in the blood which is saturated with oxygen, which is in arterial blood flow, it is 95 to 98 to 100%. Now coming to one term, that is methemoglobinemia. What is methemoglobinemia? Methemoglobinemia is a condition. Normally, you know that heme molecule has iron binding, that is bound to the ferrous form. The iron existing bound to the heme molecule is in the ferrous form. Now, suppose this ferrous form gets oxygenated and it becomes ferric form. Disorder characterized by the presence of ferric form of iron rather than the ferrous form of iron in the heme molecule. So that condition is known as methemoglobinemia. Now this hemoglobinemia, this causes decreased ability to bind oxygen. The ferrous iron will have increased affinity for the bound oxygen. So this ferric molecule, this itself will not bind oxygen. But at the same time, the ferrous form which is existing, which is bound to oxygen, it will not allow the deloading of oxygen from these three molecules also. So this is a condition of methemoglobinemia, which causes oxygen dissociation curve to shift again to the left side. The sigmoid curve, this is again shifted to the left because it does not allow release of oxygen to the tissues. So the binding of oxygen to methemoglobinemia results in increased affinity of oxygen to the three other heme sites that are still ferrous. So this leads to an overall reduced ability of the RBCs to release oxygen. So hemoglobin molecule, it's a combination of 4 heme molecules. So one of it gets ferric and it prevents the unbinding of the oxygen from the other heme molecules also. So the associated oxygen hemoglobin dissociation curve is shifted to the left. Now, when methemoglobinemia concentration is elevated, then that causes tissue hypoxemia. And tissue hypoxia or the blood hypoxemia, that causes chocolate brown color. That gives a chocolate brown color to the blood. So arterial blood with high methemoglobin level is characterized by a chocolate brown colored blood as compared to the normal bright red blood color. Causes, it can be an acquired condition. It happens in the presence of amyl nitrate, certain drugs like Depson, bismuth nitrate, certain antibiotics like trimethoprim and sulfonamides. Then because of some local anesthetics, especially the articaine, prilocaine, and aniline dyes. These are the drugs that can cause methemoglobinemia. This is the appearance of the blood. It will be chocolate brown colored as compared to the normal oxygenated blood, which is bright red in color. What will be the signs and symptoms? If methemoglobinemia percentage is more than 1, you will again become same symptoms which you are facing with hypoxia. That is, shortness of breath, that is dyspnea, cyanosis. There will be altered mental status like confusion and headache. If the condition worsens, patient goes into shock, circulatory shock, so there will be hypotension. Cardiac muscles can get affected, causing dysrhythmias. There will be seizures because of the brain getting involved. There can be coma, and finally patient can die. To treat, you need to give higher concentration of oxygen, supplemental oxygen, and the typical antidote is you have to treat the patient with methylene blue. So methemoglobinemia is treated with methylene blue. Now describing what is the respiratory failure once again, coming to the types of respiratory failure. So we have respiratory failure that's defined as partial pressure of oxygen below 60, that is a condition of hypoxemia, and hypoxia is decrease in oxygen pressure of the tissues, but we label it or define it with arterial levels, that is PaO2 less than 60, that is hypoxemia, but we use them interchangeably. So respiratory failure is defined as hypoxia with a partial pressure of oxygen less than 60. It can be type 1 or it can be type 2. So what are the differences? If there is hypoxia with hypocarbia with increased alveolar arterial gradient, it is type 1. So low oxygen, low CO2 and raised AA gradient. This is your type 1. You have to remember this. Hypoxia with hypocarbia with raised gradient is type 1 respiratory failure. And when do you find it? It happens in conditions of pneumonia, pulmonary edema, pulmonary embolism, and asthma and ARDS. So remember this, asthma is a one condition, don't get confused. Asthma causes type 1 respiratory failure. ARDS, pulmonary embolism, edema, this we already read while we were discussing the lecture, that all conditions causing increased AA gradient. These are the conditions causing increase because of the deposition of the plasma proteins, because of the diffusion of interstitial fluid, because of the perfusion defects, because of the ventilation defects. So there is increased alveolar arterial gradient with hypoxemia and with hypocarbia. What is type 2 respiratory failure? Now, type 2 respiratory failure means hypoxemia will be there. So, tissue hypoxia or hypoxemia with arterial pressure of oxygen below 60 accompanied with hypercapnia. So, if there is PaCO2 also rising, that means patient is not able to ventilate out. There is breathing difficulty, there is ventilatory defects causing alveolar hypoventilation, which is not exhaling the CO2 out of the system with normal gradient. So whenever there are ventilation defects, alveolar hypoventilation, that causes normal alveolar arterial gradient. That condition is type 2 respiratory failure. So hypoxia will always be there. With hypercapnia and normal gradient is type 2 respiratory failure. It is seen in COPD most commonly, and you have to remember this. Asthma will cause type 1 failure and COPD will cause type 2 failure. In cases of, in cases of obstructive sleep apnea, in cases of reduced respiratory drive, under drugs like barbiturates, trauma, all these conditions will cause decreased alveolar ventilation causing CO2 accumulation. Conditions of neuromuscular diseases where the respiratory muscles fail to breathe, there is cervical cord lesion, there is diaphragmatic paralysis, myasthenia gravis, GBS, or there is a thoracic wall defect when lungs are normal, but extrapulmonary defects like the flail chest when the muscle defects are happening, or kyphoscoliosis because of the bent in the spinal cord, in the vertebral column. So how do you manage? In type 1 respiratory failure, you will have to treat the underlying defect, and of course, you give a high flow of oxygen. Remember this, there is low CO2, low oxygen, and high gradient. So you give a high flow of oxygen so you can improve the condition after, of course, treating the underlying cause. Whereas in case of type 2 respiratory failure, there is low oxygen with high CO2 already existing. So you do not give a very high flow of oxygen. You have to treat it slowly, give low flow of oxygen so that body has enough time to breathe out this accumulated CO2. Otherwise, there will be a sudden lung collapse. So the respiratory centers, they are relatively insensitive to CO2, and there is hypoxia. Oxygen therapy has to be given slowly, low flow oxygen, treat the underlying cause, and you might also require assisted ventilation. What is type 3 respiratory failure? Type 3 respiratory failure is a perioperative respiratory failure. So this is occurring due to lung atelectasis, and it is most commonly seen, or a term used when lung failure or lung atelectasis happens following any surgery. So atelectasis happening perioperatively, it is termed as type 3 respiratory or a perioperative respiratory failure. It is seen in conditions of general anesthesia, decrease in the functional residual capacity, that is FRC is reduced, leading to collapse of the dependent lung unit. Then atelectasis, such atelectasis, they all require conservative management. You need to give a physiotherapy, chest physiotherapy, frequent chest change in position, upright positioning, aggressive control of the abdominal pain so that the patient can have abdominal breathing. Otherwise, because of abdominal pain, the patient holds the abdomen also. So there is holding, abdominal holding. Then you can also try the non-invasive continuous positive pressure ventilation, that is CPAP. Continuous positive airway pressure. Then comes what is type 4 respiratory failure. So type 4 respiratory failure is a hypoperfusion of the respiratory muscles. It is secondary to hypoperfusion or a circulatory respiratory failure. So now coming to the last part of our chapter, that is respiratory failure, just quickly revising the LMRPs, that is the last minute revision points. What happens if there is anemia? In anemia, you will find there is low hemoglobin concentration. So there will be total oxygen will be low, anemic hypoxia. But whatever hemoglobin is there, that is saturated. So there is oxygen saturation will be normal. Oxygen dissolved will also be normal. So the partial pressure of oxygen remains normal. So there is no hypoxemia here, but there is anemic hypoxia. So total oxygen content is decreased. What happens in polycythemia? Just the reverse. Hemoglobin concentration is high. So total oxygen concentration to the tissues is high. But all the hemoglobin present is saturated. So the saturation is normal. The dissolved oxygen content also remains normal. So the PaO2 is normal. So what happens in COVID? What happened in COVID? What was challenging in COVID was the hemoglobin concentration was normal, but still there was tissue hypoxia. Why? Because in the initial phase, whatever hemoglobin was present, that was saturated. So it was initially saturation was normal, but the oxygen, dissolved oxygen in the blood was reduced. So the partial pressure of oxygen had reduced. So there was decreased dissolved oxygen, causing tissue hypoxia. And later phases, the saturation of the hemoglobin also started dipping. And even now, if you try to treat with high oxygen also, patients were not able to recover because of the extensive amount of tissue hypoxia which had already happened. So the patient felt, I am very fine. Every time you were measuring, you were finding that the saturation of oxygen saturation is normal, but the partial pressure of oxygen had already dropped. What happens in carbon monoxide poisoning? We just read hemoglobin concentration is normal, But this hemoglobin does not bind the oxygen, it binds carbon monoxide because of the 200 times higher affinity. So the oxygen saturation is decreased, but the dissolved part of oxygen remains normal. So the PaO2 remains normal, but the oxygen supply to the tissues is decreased. So I think if you understand without trying to cram the concept, you will never make a mistake in your MCQs. So take home, type 1 is acute hypoxemic respiratory failure with low CO2, low O2 and high AA. It is seen secondary to pulmonary edema and subsequent intrapulmonary shunting. Type 2 respiratory failure, low PO2, high PaCO2 and normal gradient secondary to alveolar hypoventilation, resulting in inability to effectively eliminate the carbon dioxide, so which gets accumulated. Type 3 is atelectatic or a perioperative respiratory failure, and type 4 is a circulatory or a hypoperfusion defect of the respiratory muscles. So the patient is in, because of the patient being in shock. We can bring this class to an end. We have done the respiratory failure with you completely. If you have anything that you have not understood, you can send the questions to us in the mail, or you can write to us on the mail, or you can message us on any of our numbers. We will take back your questions and we will come back to you. If you want the notes, you will have to come to the DBA, Dr. Bhatia's Academy. You can download the app and you can learn from the app. The apps are available on both the platforms, iOS as well as the Android platform.